Hi, this is Dr. Joannides. I'm the Chief Medical Director at Optimum Re, and this is the Optimum Academy, Breast Cancer 101, video number 1 on breast cancer screening and testing modalities. So let's get started. So considering breast cancer, each case is unique and is a product of family history, environmental, and other factors. So breast cancer risk factors are nonlinear, meaning certain risk factors increase the risk more than others. The new Optimum Re breast cancer ratings stratify risk based on the inherent differences in this riskiness. And we've added a new feature called the risk score, which we'll be talking about in later videos. That's a unique feature only available at Optimum Re in the manual considering breast cancer. So considering breast cancer stats, 3.8 million breast cancer survivors were alive in 2019, and they may still be applying for life insurance. Approximately 1 in 8 women will be diagnosed with breast cancer in their lifetime. Approximately 20% of breast cancers are diagnosed as in situ, meaning they're within the duct or within some structure, whereas 80% are invasive. So they go through the duct and into the breast tissue. The staging is local breast cancer, 64% of breast cancers, and that's stage 0 or 1. Regional, 27%, and that's stage 2 and 3. And then metastatic, 6%, that's considered stage 4. So when we redid our manual's breast cancer section, we noted that the nomenclature to describe the tissue histology and molecular description in breast cancer is changing. So considering breast cancer surveillance. So careful age-appropriate surveillance and early detection are the key to reducing breast cancer deaths. Although people are fearful of having the test done, it's something that needs to be done routinely in order to catch breast cancer in an early stage. We are assuming that applicants with a history of breast cancer in the past are followed closely post-treatment and are receiving all the necessary surveillance. And there are high-risk families that have several first-degree relatives with breast cancer at a young age, or happen to have some genetic mutation that promotes breast cancer in those particular family members. So those are things that we are on the lookout for when reviewing somebody's application for life insurance. Now, this is a busy slide, but basically it is the BI-RADS mammography scoring table, and it shows what the normal scores are, like 1 and 2. So if you see a BI-RADS 1 or a BI-RADS 2, there's a low risk of malignancy. Score of 3, a BI-RADS 3 is probably benign, but there's some element that is a little problematic and needs to be watched closely. And then BI-RADS 4 and 5 are more suspicious, especially 5, which is highly suspicious for malignancy. So it's careful to review all mammograms on applicants applying for life insurance and see what their trend is, and if they have any suspicious findings that need to be evaluated before they can be accepted as a candidate for life insurance. So what tests are done to determine the BI-RADS score? Mammography can be done, and it can be done both in 2-dimensional and 3-dimensional ways. So the conventional 2D X-ray examination of the breast, called a mammogram, show it's basically taking pictures of the breast in 2 dimensions. A more recent test is the 3D breast tomosynthesis, And this is where an X-ray tube moves in an arc over the compressed breast tissue, capturing multiple slices and imaging of the breast from different angles. And then these digital images are reconstructed or synthesized into a set of 3D images by a computer. These 3D images help minimize the normal tissue overlap that can hide cancers, especially in women with dense breasts. Not every mammography suite is equipped with 3D tomosynthesis, but some are, and they use it to their advantage. And just one point, especially when COVID vaccines were more frequently used, they may cause unilateral axillary adenopathy. So mammography should be delayed at least a month after vaccination. So perhaps a lymph node that becomes enlarged from the COVID vaccine doesn't cause consternation when the mammography is done. There's also a test called breast elastography. And it's kind of like the same kind of study that would be done on the liver when a fibroscan is done, but this is done on breast tissue, and it measures the hardness or softness of a breast lesion. So I don't see this on a regular basis, but in case you come across it, there is a test called breast elastography, and it may be abbreviated BEXA, that may be reported in the attending physician statement. So I have a quiz. So, and you'll notice Charlie Brown is attempting to kick the football, so maybe you know what's coming. So my quiz is, what percentage of women have a BRCA gene? And then also, what percentage of men have a BRCA gene? So think about that for a minute. Like how frequently people have BRCA genes. Okay, so this is from the CDC, and if you'll notice what I circled in red at the bottom, it says in small print, BRCA1 and BRCA2 are two genes that are important to fighting cancer. They are tumor suppressor genes. When they work normally, these genes help keep breast, ovarian, and other types of cancers from growing and dividing too rapidly or in an uncontrolled way. So basically what they're saying here is that everybody has BRCA genes. Everyone has two copies of BRCA1 and BRCA2 genes, one copy inherited from their mother and one from their father. So everybody has BRCA genes. Normal BRCA gene provides instructions for making a protein that acts as a tumor suppressor and plays a role in repair of double-stranded DNA breaks. So these are helpful genes we all have. Tumor suppressor proteins help prevent cells from growing and dividing too rapidly or in an uncontrolled way. So the BRCA protein is also involved in repairing damaged DNA. However, if a person inherits a BRCA1 or a BRCA2 gene that has mutated, so a mutation, that's what we're concerned about, from one parent, they still have a normal copy of the BRCA1 or BRCA2 gene from the other parent. And you can see on chromosome 17 and 13 where the BRCA1 and BRCA2 genes are. So we have these genes normally, but if there is a mutation to them, that's when things go south, and those genes are not able to help repair broken DNA. So these variants or mutations put people at significant risk. So for breast cancer, 13% of all women will develop breast cancer, but BRCA1 variants or mutated BRCA1 genes. In those women, 55 to 72% will develop breast cancer by the age of 70 to 80. So the risk of breast cancer goes up significantly if a BRCA1 gene mutation is present. If a BRCA2 mutation is present, the risk is also high at 45 to 69%. And then BRCA variants or mutations also put women at risk for ovarian cancer. 1 to 2% of all women will develop ovarian cancer. However, the percentage is much higher if there are BRCA1 variants mutations or BRCA2 variant mutations. So the risk of breast cancer can be reduced by 50% by premenopausal oophorectomy and 95% by prophylactic mastectomy. So that's why women who have BRCA mutations should consider surgery of both having their ovaries removed and having prophylactic bilateral mastectomies. The risk of ovarian cancer can be reduced by 95% by prophylactic oophorectomy by age 45. So these are tough decisions to make, but in order to reduce the risk of BRCA variants, sometimes they're necessary, and we'll note that in people who apply for life insurance. So again, these are the two variants that we're concerned about. And if you look at bullet number 3, cancer can occur at younger ages in people that have BRCA variants. And in bullet number 4, although BRCA occurs in a very small percentage of women, it represents 5 to 10% of all breast cancer cases, because the likelihood of breast cancer is so much higher if a BRCA variant is possible. Also, the 5th bullet is BRCA1 variants are likely to be triple negative, and that's one of the worst types of breast cancer to have. That means that there's no estrogen receptor, progesterone receptor positivity, or HER2 compared to BRCA2 variants. There's also an increased risk of prostate cancer, colon cancer, melanoma when BRCA1 and BRCA2 variants are present. Now, just to give you an idea about this, what do BRCA genes normally do to repair DNA? So if you get a small pothole or a small break in the DNA, that's easy to repair. So the BRCA genes would be one of the key helpers in repairing that small damage to the DNA. So if you repair the break early, things can be restored to normal and you're back on the road again, right? However, if the BRCA genes are mutated, that repair is not going on, and so in the bottom right, you get a wipeout of the whole road, basically. So that's when cancer can develop, mutate, and overtake the body in some way or another. So here's a BRCA quiz. So a 38-year-old woman works for the New York Times and is applying for $2 million of UL. Her mother had breast cancer at age 40 and ovarian cancer at age 64. So obviously already a strong family history, correct? Her grandmother had a history of breast cancer. She has 2 older sisters who have had breast cancer at ages 36 and 39, and she's 38 presently. So let's consider these 3 BRCA variant scenarios. So if she's tested and it is available and negative, how would you feel about her application? If she had testing but it's unable to be found, how would you advise the underwriters to handle the case? Or if she's planning to have the test done, how would you approach this case? So think about those 3 scenarios for a minute. I'll give you my take on it, which you may or may not agree with, but If it's available and is negative, so she's tested for BRCA 1 and 2, and neither show a mutation or variant, she still has a very significant family history. So it doesn't really matter whether the BRCA is positive or negative. She has such a strong family history that something is going on in her genetic makeup, whether the test is available, negative or positive, she's still at super high risk because of the family history. So as in bullet 2, if it's unable to be found, same situation. I mean, really in this kind of a case, you don't really need a BRCA result in order to make your decision. She's at high risk no matter what any genetic testing shows. So I would go based on the family history that she's at significant risk for breast cancer. If she's planning to have the test done, there's, you could wait, but it's not really going to help you whether it's positive or negative. She's still a high risk candidate, right? So what are other cancers linked to BRCA1 and BRCA2? Fallopian tube cancer, primary peritoneal cancer, breast and prostate cancer in men, so men can get breast cancer, pancreatic cancer in men and women, and then a really severe disease. If a child inherits BRCA2 from both parents, there's a disease called Fanconi's anemia, which is life-threatening, which can occur. So there's other abnormal genes that can be variants that can also be associated with breast cancer. One of the more frequent ones you may see is PALB2. But let's go through this list here. There's a test called the BRCA Analysis Large Rearrangement Test, or BART. And it was developed to identify additional BRCA mutations not identified by the typical myriad BRCA analysis. So if you see something called BART, which is the transportation system in San Francisco, also take warning. PALB2, abbreviated, it stands for partner and localized of breast cancer 2, and it's a partner of the BRCA2 gene, so still a problem. It provides instructions to make a protein that works with the protein from a normal BRCA2 gene to repair damaged DNA and stop tumor growth. So if something's wrong with the PALB2, person's at risk, and an abnormal PALB2 gene mutation increases breast cancer risk to 33 to 58%. And inheriting the abnormal PALB2 gene from both parents also causes Fanconi's anemia with suppressed bone marrow like BRCA2. So that's another genetic marker to be on the lookout for. Other abnormal genes associated with breast cancer is one called TP53, which also affects the repair of damaged DNA. So now we've got a lot of things to be aware of. So we've got the BRCA, the PALB2, the TP53, and BART. So if you see any of those names mentioned, take heed. So what are other breast studies in addition to the mammography or genetic testing that might be done? So an ultrasound might be ordered as an adjunct to mammography. It's not used alone for screening, but usually used in combination with a mammogram, and it helps to look for cysts, solid tumors, especially in dense breasts. It's not useful to evaluate for calcifications. So that's one particular thing where ultrasound is not helpful. But MRI, or magnetic resonance, provides no radiation. So especially if somebody has had a lot of radiation for one reason or another, people may rely on the MRI. It can pick up small cancers missed by mammography and dense breasts. It can be used in women with breast implants. Can be used more frequently in women below the age of 40, with dense breast tissue to limit radiation exposure, and it can be used in young women who had chest irradiation in the past, but it's also not useful in breast calcifications. Now, let's say a suspicious area was found in the breast with maybe some microcalcifications that looked worrisome for a cancer. So maybe a biopsy is recommended to determine whether this lesion, nodule area with calcification is possibly breast cancer. So a core needle biopsy can be done with vacuum suction and follow-up X-ray of the specimen. So these are the kind of things that the core needle would look like in the picture on the left. And then the picture on the right kind of shows you how the core needle is inserted, and then vacuum suction is used to bring the biopsy out so that they can be looked at by a pathologist. So you'll notice in these core needle specimens, when the X-ray is taken, there's actually little white spots in the specimen, and that's the calcification that was worrisome. So you take an X-ray of the specimens after they're retrieved to see if you got some of the calcification you were worried about in the first place. And you usually leave a marker where the biopsy was done. So if there is something worrisome, you know exactly the location of that area that was biopsied. So these are important things which may be done to evaluate worrisome areas on a mammography or other breast studies. So these breast calcifications, this kind of gives you an idea of what the risk is of different kinds of microcalcification. So you'll look to the left, which is the least worrisome. And these are just round calcifications. They may be semi-lunar, look like half of a moon, and that's a low risk. If they get to be round, regular, as in the circle number 2, the risk goes up to greater than 20%. The dusty, very delicate calcifications, the risk is greater than 40%. Then the point irregularly shaped calcifications are more worrisome. And then the worm-like calcifications, that's the most worrisome, and those are universally regarded as significant and worrisome for cancer. So just in general, breast cancer 5-year survival, and this is data from 2019. Overall, for localized stage cancer, success rate is 99%, 86% for regional disease, and 27% with metastasis. And you can see to the left the overall stats for breast cancer. 91% of women with breast cancer history are alive at 5 years, 84% at 10 years, and 80% at 15 years. So early diagnosis and adequate treatment can help women with breast cancer and men with breast cancer live a long life. But early diagnosis is the key, and routine mammograms may have been delayed due to COVID-19, and people still may be a little sluggish about getting their mammograms back in gear. So that may delay diagnosis, and lesions may be found at a later stage. So that completes our first video in Breast 101 in the Optimum Academy series.